Thank you very much, Sue, for introducing me. And yeah, life's busy, but we're midwives. We can cope with that. So yeah, systematic examination of the newborn. Are we actually ready for this? And what do we need to be ready for? So let's take a very quick whistle-stop tour, and it will feature some of those documents that Sue was just talking about there. So we need to look at those new NMC requirements. What are the students' requirements now? Because I think unless you work in education, you might not be that familiar with them. And also, if you're already a NIPE practitioner or systematic examination of a newborn practitioner, we've got to do that CPD, haven't we? It's important. We don't want our practice to become stale. And there's lots of variations across the country that we need to have a think about. Okay, so let's start with our student midwives then. So what do our student midwives have to do? The performing of the newborn and infant physical examination, and I'll go on and call that NIPE for now to save a little bit of time, is absolutely now recognised part of the undergraduate curriculum and part of the midwife sphere of practice. And the majority of higher education institutions currently provide or are planning to include that NIPE examination training into their undergraduate pre-registration curricula, as it is part of those new standards that Sue was waving there, and there's a little image of it there. Now, some universities have been doing that anyway under the old standards. We didn't have to put it in under the old midwifery education standards, but you like to look ahead, you like to look where midwifery is going and keep on the ball. And several universities included both the theory and the practice in their programmes, so their students were coming out as midwives who could practice as a NIPE practitioner. Other universities just had the theory in there, and the practice was a bolt-on afterwards. Pros and cons to all approaches, but what we have to do now is both the theory and the practice. So this is how student midwives are doing this. So newly qualified midwives who've undertaken the module as part of their pre-registration midwifery training must have completed both theoretical and clinical components. So past courses, you may have qualified, as I said, and just done the theory. You can't be an NIPE practitioner until you've done that practical component as well. Students on the new standards, so courses that are being validated mostly over COVID, which was an interesting experience, will have that theoretical and practice elements, both of those included. And in terms of the theory, the university tends to take that and we'll put it into modules. We'll develop the students over time, introduce them to some simple normality in the first year, for example, and then introduce that systematic examination as they move through their programmes. The practical side tends to get assessed, obviously, in the clinical area. We may simulate OSCEs in the university, but students need that hands-on experience. And it's the MORA, the Midwifery Ongoing Record of Achievement, that most of the universities are using now across the country. However, thought number one is it only has one proficiency related to NIPE, or the systematic examination of the newborn. And the wording of it's there, that the student is able to undertake a full systematic physical examination of the newborn infant in line with local and national evidence-based protocols. My personal thoughts, and I'll put it out there for you to all muse over, is you need supplementary documentation. There's not enough detail there. We've been running NIPE training for postgrad and undergraduate for a number of years now. That needs breaking down into lots of component parts. What does that actually mean? We need quality, we need robust standards. And certainly at Birmingham City University, we've developed supplementary documentation, and I think that's been mirrored across the country where practitioners are experienced in doing that. And that's something I would urge every education institution to do. You need supplementary documentation. Okay, so why are we doing this? There is some evidence base, which is nice. We don't do anything in midwifery unless we've got an evidence base. It's important to have that. There's a cost saving, which is good. We had, it's appropriate for low-risk babies. It's clinically effective. It provides continuity of care. We've got increased parental satisfaction. This is good on many, many fronts. And if you look at this part here, we are saving money, and we all know at the moment that the NHS could do with saving quite a lot of money and perhaps repurpose, where things are. And we will be part of the solution by midwives and our students taking this on. I'm not going to play the clip of Jo there, who's one of our recently graduated midwives, unless we've got time at the end, anybody wants to watch it, but I will leave it to be available for everybody to view the future. But very positive experiences of having this as a qualification on the old standards and being able to go forward to a job interview and say, actually, I have skills that you want as an employer.
Hi, I'm Jo. I'm a newly qualified band 5 midwife.
Sorry, we did get a little bit of Jo there, but moving onwards for time. So all our students are going to be coming out with this qualification. Some of you who are qualified midwives may or may not have this qualification. So there's some thoughts there about, do I need to upskill? What do I need to do? Universities are ready for that. And if you feel that, hang on a minute, I need to upskill myself, I need to move forwards in my practice because all these new people coming through have got things that I haven't got, get in touch with your local universities. So for existing and newly qualified NIPE practitioners, we need to think about that CPD, as Sue was pointing out. It's really important. You've got to maintain your skills. And to provide a duty of care, an appropriately trained health professional must carry out the NIPE examination. It's got to be a trained person. And they need to have undergone the relevant training and a locally agreed competence assessment. Now, it can be a midwife, we've definitely got a role in there, but it can also be a nurse or a health visitor who has successfully completed the accredited examination of the newborn study programme. So there's scope to work there within a multidisciplinary team and in different ways. It can also be a doctor, and that's where traditionally these examinations have been done. Or as we've already said, we can have our new standards where they're coming out with the qualification. So as providers then, you need to be really diligent to ensure that all the required elements of a course have been successfully completed as a pre-registration midwife coming to work for you. At the moment, we've got a very mixed economy. So those are the types of questions that you need to be asking of employees coming in to make sure that you're providing a safe, efficient and an appropriate service. And although we have nursing colleagues who do the NIPE examination, nursing associates are not eligible to undertake this examination. Individuals need to hold professional qualifications and be registered, such as on the GMC or the NMC. However, physicians associates may be able to do. That's a little more of a grey area depending on their training. We tend to do as midwives that early examination before 72 hours, but we also in our training, we encompass a 6 to 8 week check as well to make sure our midwives really are robust and fit for future practice, wherever midwifery may extend itself to over time. Traditionally, this is your doctors, it's the GPs who are doing this, potentially health visitors and potentially physicians associates. So the government under PHE, has actually put together an annual learning framework that we can all as NIPE practitioners adhere to, and they recommend it. It's not statutory, but it's recommended. So it has an annual learning framework that came out last June, so just under a year ago. And it has 3 elements of the framework that are really, really important. Firstly, they recommend that you do the NIPE e-learning modules that are on e-learning for health. So everybody can have access to those, particularly if you're working in the health service. All our students have access to that. So it's a really good, robust resource. It suggests that you do discussions of national standards, clinical pathways, training and education resources. There are clear pathways for referral within NIPE, and local areas should be adhering to those. So practitioners need to update themselves on the latest amendments or changes. And they changed in 21, I do believe. And they also recommend an attendance at a local NIPE update session as well. And I know Lindsay and Anna are going to talk about some of those updating ways in a moment. In addition, they talk about NIPE working in partnership. So it's really good practice to go and visit specialist clinics or multidisciplinary discussions or meetings about case studies. For example, you could with cardiac abnormalities, if you think, you know what, I'm a bit rusty on that, get yourself down to the neonatal unit, get yourself down to a cardiac clinic and arrange some updating so that you're aware of what those heart sounds, normal and otherwise, can sound like. And also a NIPE reflection is recommended as well. And that can also form part of your NMC revalidation as well. So not reinventing the wheel, we can use the same thing for two different purposes. Just a little note though, if you're a trust that has an in-house training course for actually getting people qualified as a NIPE or a systematic examination of the newborn practitioner, you need to seek university accreditation. Public Health England have this as a stipulation because you may train people locally, but that won't be a universal qualification. So individuals won't be able to move across the country. And it's about quality, it's about standardising and having that higher level thinking at level 6 or level 7 that the universities can provide. So some challenges then, some thoughts to move you on and ponder about. Decolonising. So very nicely, Sue mentioned the RCM, decolonising information that's out there at the moment and newly launched. We probably need to decolonise our examination of the newborn literature as well. Historically, very little attention being paid to the significance of skin colour and the variations when we're teaching. There's a lack of awareness that many conditions can be more difficult to recognise on darker skins. There's a definite gap in the clinical and theoretical education that as universities we need to step up to and rise to that challenge. We're always welcoming suggestions on how we can do that and working in partnership. We need to kickstart and continue that discussion. It's a ripe time for doing that. We know that, ethnic origin continues to have a significant impact on mortality rates. Stillbirth rates of Black and Black British babies are over twice those for white babies. Neonatal deaths are 45% higher, not acceptable at all. And from a NIPE point of view, we can do our part to assist in remedying that. And again, we've got disparities between Asian and Asian British ethnicity, stillbirth and neonatal death rates, 60% higher than white babies. It speaks for itself, doesn't it? I don't need to labour that point. It's not right. So debates for education and practice there. And you can see here, I have to tell you about this. This is one of our anatomage tables. It's like a massive iPad about the size of a bed. And it works like an iPad, press buttons, fiddle them around, and we can teach our students using this. We've got some amazing facilities at universities, and particularly at BC, we're very proud of our new simulation facilities that we get to play with and our students get to play with, but most of all, they learn, which is fantastic. So what are the key challenges around decolonising for you in education, in practice, in teaching? What questions do you have around education? Are you actually using that supplementary booklet that I've just said is really, really important and I'm passionate about? We're happy to share it at BCU, and I'm sure Lindsay is as well. How confident are you in teaching? So these students are all going to be flying through to the clinical areas. You've got them for 50% now of their clinical time because the NMC said so. What are you going to do with them? How are you going to teach them and test them and put them through their paces, but in a supportive way? How do you give feedback that's supportive and doesn't scare the life out of them or put them off? Would you like to share your models of teaching students? Are you supported for your CPD once you are qualified? How do you bring existing midwives up to the current standards when there's a little bit of a gap there potentially? Have you met your annual learning framework guidance? Did you know about it? Are you thinking now, crikey, somebody comes and checks, am I? Should I? Is it being used at your trust? Is it something you need to introduce? Is there a nice quality improvement project? I can feel a project going on there, and then a publication to go with it. You have to publicise everything that you've done. Do you need to network? Networking is fantastic. This isn't about one person being better than another. This is about quality and standards and sharing and improving care, education and practice. what conversations do you want to start? There are some resources with the live links on there. And just to say, it's a little bit like raising a child. It requires a team. There's no point just me doing it, for example. So at BCU, where we have 125 students per year, we've got 6 of us who are doing examination of the newborn. We did have 7, but somebody's just leaving. It's like, oh, but we've got a new person coming in. So we will have 7. I just can't put her name on there just yet. So we run the undergraduate courses and we run the post-grad course as well for those midwives that haven't got the qualification yet. And we are ready in Birmingham, like many places, for the challenge of systematic examination of the newborn to a high standard. Thank you very much for this whistle-stop tour.